in Rochester, New York. That was back in the 90s. I had a dream that by 2020, I wouldn't need to go throughout the country and world anymore to teach people about evidence-based practice. It is now 2018, and I would like to say we're 2 years away from accomplishing that dream, but realistically, with what we see throughout our country, we are at least another 20 years, maybe 30, until EBP is in the DNA of every practicing clinician. So we have great opportunity, but there continues to be multiple barriers that exist, both in educational programs as well as in our healthcare system, that slow the advancement of evidence-based practice down. So for many years, we have defined evidence-based practice as a problem-solving approach to the way we deliver healthcare that integrates the best evidence from well-designed studies, combines it with the clinician's expertise and patient's preferences and values. That leads to the best clinical decisions, which then lead to the best outcomes. However, we could do the best job of giving people the knowledge and skills that they need to consistently implement evidence-based practice, but when they go back to an environment and a culture that doesn't support it, that's where the system issues hold people back. And we'll talk about this more later, but culture truly eats strategy for breakfast, lunch, and dinner. So as part of being able to move a whole system forward in evidence-based practice, this takes culture change. And we all know it takes 5, 7, a good 10 years to truly change culture. I was passionate about evidence-based practice way back in the 90s. Again, when I really was pushing this from the University of Rochester, where I was at that time in my career. But I became much passionate about this when I almost lost my daughter, Kaylin, in Australia due to non-evidence-based healthcare. I wish I had time to share Kaylin's story with you, but she almost died from a ruptured appendix. Yet no physicians in Australia would take me seriously. And as a pediatric nurse practitioner, I knew what was wrong with Kaylin, but couldn't get anybody to believe me. She had a surgeon that had her jumping up and down on her right foot in the emergency room saying, where a child can do this, they don't have an abdominal issue. And I said, where is the evidence behind jump on the right test? Because we don't do that in America. Kaylin almost died from this ruptured appendix because the physicians would not listen to my patient, my family, my parent preferences, my clinical judgment. So thank heaven when they finally listened, it was 10 days past the onset of symptoms. She had full-blown peritonitis, pelvic sepsis, and to make a long story short, when I was able to get a consultant surgeon in who took her to OR and flushed her peritoneum for over 2 solid hours, and again she almost died through this process, but if it wasn't for my advocacy, I really think Caitlin would have died. Sure. But again, she has such a resilient attitude, and she now teases me and says, Mom, if I had to go through what I went through to help you advance evidence-based practice throughout the world, then it was well worth it. The bottom line is, and for those of you who know me so well, I always ask people, what would you do in the next 5 to 10 years if you absolutely know you cannot fail? You've got to keep your dreams in front of you. If you feel yourself getting tired, feeling like you want to give up with whatever you're doing, put the dream back in front of you. So well over 10 years ago, I had a dream for a National Institute for Evidence-Based Practice that could advance and improve care, quality, safety, and reduce costs. And I started pitching that dream to the Fuld Health Trust out of New York City. Well, finally, year after year, for 10 years, I visited that trustee. I shared with her how a ramp up across the country in evidence-based care could really improve quality and outcomes. She finally said, after 10 years, Bern, how much would it take for you to launch this institute? And I am a competitive person, so the largest gift they ever gave was $6 million. So I said $6.5 million, and she finally said, I think we can do it. So last spring, we received this wonderful $6.5 million gift to establish the Fuld Health Trust National Institute for Evidence-Based Practice here at Ohio State. And I am so blessed to be able to work so closely with Lynn Gallagher-Ford and the whole fabulous team that we have here to really advance evidence-based practice throughout the country and throughout the globe. So we got to dream big. We have to believe in those dreams. We have to take risks. And then we have to persist through the character builders until our dreams come to fruition. And I think a great example of that was Theodore Geisel, who wrote the first Dr. Seuss book. He approached 23 publishers with his book. They thought it was a crazy idea. Thank goodness he didn't stop and went on to the 24th publisher, and that publisher then sold 6 million copies of the Dr. Seuss book. So I always say success is going from one failure to the next with enthusiasm, So get excited the next time somebody rejects your proposal or your idea. And I want you to think steps closer to a yes. So a few years ago, there was a lot of national buzz about the triple aim in healthcare, which is enhancing the patient experience, which includes quality of care, improving population health, and decreasing costs. But then 2 years ago, another publication came out that said it's not only the triple aim in healthcare, but it's the quadruple aim, and we should add a fourth aim, and that is to improve the work life of healthcare providers. If you are not aware, the National Academy of Medicine has launched a national action collaborative on clinician well-being and resilience. Sparked last spring because the prevalence of depression, compassion fatigue, and suicide is rising in physicians, nurses, and other healthcare providers. So the National Academy of Medicine, and I have the privilege of serving on this action collaborative, said we've got to do something about this, because if clinicians are burnt out, depressed, they're going to make more medical errors. The quality of care is going to be poorer. And if you haven't seen our latest national study on the health of nurses in the Journal of Occupational and Environmental Medicine, I'd encourage you to look at that article. What we found in this national study is that nurses, more than 50% of our sample across the United States, reported that they were in poor physical or mental health. And that was to the number of medical errors that they made. Specifically, depression was the strongest predictor of medical errors. Now, as we look at the quadruple aim in healthcare, evidence-based practice can absolutely enhance every single aim. So it's really important for chief executive officers, for chief nurses throughout our country to recognize that if they invest more in evidence-based care and getting their providers more skilled in EBP, they're going to achieve the quadruple aim a lot faster. Preventable medical errors are now the third major cause of death in America. And many of those errors, again, are made due to physicians and nurses who are burnt out, who are fatigued. It's also due to poor communication amongst the interprofessional teams, as well as lack of the use of best evidence to guide practice. We still have so much variability in healthcare all across the United States. Our team does 5-day evidence-based practice immersions all throughout the United States, and people are all working on the same issues. Whereas if we just have a clearinghouse, which we will do from the National Fuld Institute, people won't have to figure out the same solution over and over and over again. Poor quality health care costs us billions of dollars every single year, and the health care spending, we know, could be reduced by 30% if patients throughout our country consistently receive evidence-based care. So again, we can solve the quadruple aim with evidence-based practice, and we can definitely improve outcomes of our patients with evidence-based care. So if you remember back in 2003, there started to be a lot of momentum on what physicians called evidence-based medicine. And I've got a pet peeve on that. I don't think we should be using the term evidence-based medicine, evidence-based nursing, because whether we're teaching physicians, pharmacists, nurses, we all teach them the same EBP steps. But the Institute of Medicine, now called the National Academy of Medicine, they said our goal is that by 2020, 90% of the healthcare decisions will be evidence-based. Well, I will tell you, unfortunately, we are nowhere near 90% of the healthcare decisions being evidence-based. So our team conducted the first national study on the evidence-based practice competency. Back in 2014, we developed the first set of evidence-based practice competency, because prior to that time, we really didn't have research-based, evidence-based competencies for practicing nurses and advanced practice nurses. So after we developed these competencies, we said, now we have to do a study, and we have to find out where are nurses across the United States in achieving these particular competencies. The EBP competencies can be downloaded free from the Worldviews on Evidence-Based Nursing website. So we conducted this national study with 2,300 nurses from 19 hospitals and healthcare systems throughout the country. Our aims were to describe the state of the evidence-based practice competency and to determine important factors associated with their EBP competency. The mean age of the nurses who completed our survey was 44 years. 92% of them were female. 85% were non-Hispanic white. 58% had a bachelor's degree, and almost 70% worked in a magnet organization. And I think that statistic right there will speak volumes to you when you actually see the data. Because with that many working in magnet institutions, we could have assumed we're going to see a higher level of evidence-based practice competency. So here's what we found. When you look at all of the competency, we found that the nurses reported overall a lack of competency. In fact, overall, they reported they needed improvement. not just in 3 competencies, in 5 competencies, in 10 competencies, but all 24 competencies. And if you look at the spread, and this is disconcerting, the spread in reported competency between non-baccalaureate prepared nurses and baccalaureate prepared nurses was relatively small. There was a wider spread with master's prepared nurses reporting higher levels of competency, but it was nowhere near what we had hoped for. So again, we have a lot of opportunity in front of us for building competency in evidence-based practice. I think what's also important to share, we looked at correlation among the variables in this study. And what we found were very similar